to another episode of the Senior Focus. I'm so happy that you're able to join us today. My guest today is Dr. Michael Flynn. He's a physician at UMass Medical Center, and of course Donna Ostergaard. Hello, Donna.
Hi, Vic.
Hello, Dr. Flynn. How are you?
Dr.
I'm doing well, thank you.
Dr. Flynn, how long have you been a doctor?
I finished medical school back in 1993.
And where was that?
I was down at Duke University.
Mm-hmm. And during your education, did you become board certified in a particular area?
Eventually, so I finished my medical school.
Okay.
Did my residency at Beth Israel here in Boston.
Here in Boston.
After that, I had to spend a couple of years practicing before I could even become board certified, and then became board certified in 1999.
And when you said that you had to spend some time becoming experienced in practicing medicine, what would that have been?
That would have been being a general OBGYN. I
Okay.
actually practiced out of Beth Israel as a general OBGYN for 4 years before I went on to my fellowship in female pelvic medicine and reconstructive surgery, or urogynecology.
And as I said, right now you're at UMass, right?
Yes.
UMass is a big place. Where at UMass are you?
I'm at the Memorial Campus,
Okay.
so I operate out of the Memorial Campus, and I see patients out of the Levine Ambulatory Center.
So you're a surgeon.
Yeah.
Is there anything in particular that drew your interest to surgery?
It was really as I went through medical school, I realized I wanted to go into OBGYN for the diversity of patients that I could care for. And then once I was in residency, it became clear to me that I was really a better surgeon than any kind of a medical doctor or even an obstetrician. And so it became really clear to me that I should follow my strength and do that.
Now, you know, one of the things that I've said repeatedly is the numbers of seniors in our population is increasing at a rather dramatic rate. And I'm wondering, during the time when you first became a doctor to the present day, have you seen, we'll say demographically, a difference in the age of a typical patient?
Certainly from my practice, as it's evolved into the specialty, yes. As a general OBGYN, I saw much more women in their 20s, 30s, and 40s. Urogynecology, we take care of pelvic organ prolapse, urinary incontinence, and these are disorders that women in their 40s, 50s, 60s, 70s tend to get. So my typical age is a woman somewhere in her late 40s for incontinence, or in their mid-60s for prolapse.
And I understand this is a fairly common ailment.
Very common.
People might not realize how common an ailment this is.
It's estimated that somewhere in a woman's lifetime there's a 40% risk that she will have some sort of a problem of incontinence or prolapse.
And I presume that a lot of people would shy away and not want to talk about this.
Nobody wants to talk
Nobody
about,
wants to talk about
that.
this, yeah.
Yeah, it's usually a very good conversation stopper.
It's as I can imagine it would be. But
Yeah.
it's something that's very important. If someone is suffering from, you know, the symptoms of this illness, something that they need to address rather than try to brush under the rug, so to speak.
What's very nice, a recent article in one of the national papers talked about a focus on quality of life when it comes to health care. This is a quintessential quality of life problem. Nobody dies from these problems, but it can be devastating, the effect it has on your life in terms of social activities, in terms of exercise, in terms of intimacy, and just your own feeling of self-worth.
There have to be many people, women I'll say, who give up a certain portion of their active lifestyle because of the fact that they may have problems with either prolapse or incontinence. I know many, many people, at least even in my immediate family, who have issues with this, who have, say, myself, given up exercise for a short time because I was so tired of incontinence issues, and learning to either strengthen yourself or certain ways around it that can make your quality of life better. And I'm sure you deal with this on a daily basis.
Routinely, that's the first strategy most women follow when they start dealing with stress incontinence. They stop exercising, they stop doing activities because it causes them to leak, and then they have to start wearing pads because they're leaking just with coughing and sneezing and regular activities and wetting, you know, as opposed to urge incontinence, which is a little bit different mechanism. But we see that kind of response routinely. And the number of women coming into my office who think they're the only one, they realize that they're not. We do something to make it better. They will come back for their post-op visit, and they will tell me that women come out of the woodwork to tell them, oh, they had that procedure, or I've got that problem, and where did you go? And they will have 3 or 4 friends who immediately start talking about the same problem. Again, everybody thinking they're the only one.
Almost like a taboo subject in a sense for many women, especially as you age. It's not something that you'd commonly talk about, but need to talk about, or if you say, hear that person who had some type of treatment for it and is probably 90% better and can go on with life and have a quality life without the worry of incontinence or prolapse.
If you think about it, think about young children. What's one of the first things that they learn how to control? The first definition of good boy, good girl is urine control. And when they first use the potty on their own, isn't that wonderful? Isn't that great? And the discipline that happens when they have an accident. So for a very large number of people, the essence of good person, bad person goes to continence. And so that's why for so many people it's devastating, because it's so visceral, how tough it is.
Like you were saying, when someone has been treated and have a successful resolution of their problem, all of a sudden it's like, their friends, it comes out of the woodwork. Where did you go? What treatment have you had? I suppose that's precisely what I was trying to get at when I was saying nobody wants to talk about this, but it really is a very common occurrence, and people that have this problem really should speak to their physician. They don't have to suffer unnecessarily with this. There is treatment that can help them.
I'd love to say I can cure everybody. And the reality is there are some patients that we can't make better, and that's true of every medical condition. There are so many patients that we can make better, and the number of patients that will look at me after some simple procedures we do, they'll almost all say, I should have done this years ago. They think about it.
What's a typical day like for you? You wake up, you have your breakfast, you're off to the hospital. What's a typical day like for you?
For me, I'm a little different because I hold a leadership role in the Department of OBGYN, so I've got a fellowship in residents and fellows that I'm training. I've got divisional responsibilities in terms of trying to rebuild our practice, as well as taking care of patients. But on a typical clinical day, for instance, today is one of my typical clinical days, I'll be in the office, start seeing patients at 8 a.m., and I have patients going up until 6:15 at night. And I'll be pretty much in the office all day seeing patients, taking care of paperwork and things like that, and I will see all day long incontinence and prolapse. That's all that I do.
And you operate as well, right?
Yes.
So it's not only in the office, but also the operating room.
I have typically a day in the operating room, but it is important to realize there's a lot of treatment we can do that's not surgical, that we can keep a lot of patients from going to the OR. And as I said earlier, it's a quality of life problem. So some patients we'll look and we'll give them the option. Well, we can fix this surgically, or there's some non-surgical options that we can treat, and that might work fine for you. And we help women figure out what's the quality of life they want to achieve, and we try to help them achieve it. So we've got women who use pessaries, we have women who do physical therapy and are delighted, and we have women who say, forget that, I just want surgery, just fix it, and we can go that route.
Now we're going to talk about prolapse and incontinence. What exactly is prolapse?
Typically, for most women, they expect things to stay up inside the vagina. Certainly, that's the way God made you. The problem is, with age and time, with the injuries from childbirth, it's not uncommon for things to start falling out of the vagina. You'll hear many women say, my bladder's dropped. I always try to focus on not so much as the bladder dropping, but it's the vagina failing. And the best way to think about this condition is like a hernia through the vagina. Things are just falling through and you've lost support. So it might be the uterus falling down, it might be the back wall of the vagina, it might be the front wall of the vagina. But prolapse is things basically prolapsing or falling out through the vaginal opening.
How serious is prolapse?
Nobody dies from prolapse. I mean, it's got to be extraordinarily bad, and I've never seen a case where it truly contributed. Nobody's harmed by it. This isn't cancer. It truly is a quality of life problem. When I was in upstate New York, because I was practicing in Rochester for 6 years before I came here to run the division, I used to see patients in a very rural community, and it was extraordinary. A lot of women there were living with something coming out of the vagina, almost the size of a baby's head, doing their chores, caring for their horses and doing their everything. Didn't bother them at all. And my response was, if it doesn't bother you, won't kill you, won't harm you, doesn't bother you. Here's some strategies to help make sure you empty your bladder and your bowels, but we're going to leave you alone. Other women, it just decided they bother them when we do something, but it's not. It's all about quality of life and making life better.
Can you draw us a diagram of where organs should be and
Yeah. We draw a basic outline of a woman's pelvis. So what we have here, that's the vulva. Inside the vulva is the urethral opening, and then there's the vaginal opening. Now typically for a woman, the vagina will come back like so. That's the cervix, or the opening to the uterus or the womb. There's a uterus. There's the rest of the vagina. The urethra, bladder. That's the pubic bone. The anus, rectum, and then down here comes the tailbone. So if you see here, this would be a side view of a woman standing up, pubic bone here, and as I've drawn. When we have prolapse, what's happening is the vaginal walls are failing. So the quintessential, my bladder's dropped. Well, the bladder, the anterior wall comes down here. So if I were to sketch out somebody with the bladder dropping down, just the bladder, and the opening of the vulva and the vagina, but might look something like this. Again, the anus, here's the urethra coming down, bladder, again the uterus, the pubic bone. So again, somebody standing, you can see here's the anterior wall coming down. I'll have some patients where the anterior wall goes like this, with the bladder coming down along with it. The way you want to think of this, again, this is like a floor, the vagina holding it up. So we have here the floor supporting the urethra and the bladder. If the floor fails, everything falls down and comes with it.
So it just pushes through and ends up coming out.
I try to get away even from the term pushing through because
Okay.
so many people will say, and even a lot of doctors will say, your bladder's falling down, your rectum's falling down. No, the vagina's failing.
It's not holding things in place.
I will say, for instance, take a look at the table here. If this table started falling through the floor, would you fix the situation by tacking up the table, or would you fix the floor? Right? You fix the floor. There's
the
nothing wrong
floor.
with the table. It's the same idea here. There's nothing wrong with the bladder. The bladder's doing just fine. The vagina's not holding it up. Again, a hernia through the vagina. And that's what we're seeing here. And it can certainly get involved with more quadrants. Right? I said the anterior wall and the posterior wall. Okay? Well, the forces that acted on the anterior wall and posterior wall and the top of the vagina, that's labor. That's having babies. Most of the time you'll see this in somebody who's had children. And so the injuries that have occurred affect all the different areas. So women with really advanced prolapse will sometimes have women come in like so. The rectum bulging out. Okay, so what I've drawn here now, much more complex than what we had, but if you follow, here's the anterior wall coming down and out. Here's the bladder coming out along with it. Again, the vaginal wall is not holding it up. Here's the cervix coming outside. And I've got some women who literally things turn completely outside. The analogy I'll give is like turning a sock inside out. Right? So if you can imagine, here's a sock, like when you do laundry. And all that's happened is it's just been pulled out. And you end up with this, with various organs then coming along for the ride.
And that's probably where a case of surgery is the best possible hope of, would you say?
I've learned to never make that prediction. There have been some women who I've looked and said, I don't think a pessary will ever work.
Yeah.
And it works beautifully. And I've
Really?
said, yeah. And so I've always looked, I said, well, if you don't want surgery, if you want to avoid surgery, let's try a pessary. Now what a pessary is, Again, you remember I gave you the analogy of a hernia. Well, the idea of a hernia, some people will wear a girdle or a truss to hold the bulge in. A pessary is something that I'll put in the vagina that will sit in there and hold it up. And so in particular, if the defect is here or here, you can see a pessary, and I usually use a ring, looks like a diaphragm. Sits in the vagina, very comfortable. A pessary that fits well should never hurt. But it sits there and it supports it. And I've got women who've used pessaries for 15, 20 years and love them. I've had women who really wanted one. I couldn't find one that fit.
Really?
I've had patients use them for 2 weeks and say, forget this, I want my surgery. And I've had people use them for 5 years and then their bodies changed and didn't work as well. The nice thing about a pessary is, if you don't like it, take it out.
We're going to head to a break right now, but when we come back, we're going to talk about some symptoms and some treatment with Dr. Flynn.
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Please join us on Wednesday, June 20th at the College of the Holy Cross for a special day for anyone interested in learning more about the latest information on heart health, such as heart disease risk factors, stroke prevention, and how you can implement a heart-healthy lifestyle.
Charter On Demand presents How to Turn Your Home into a Movie Theater. Find your Charter remote and pick it up. Locate Channel 1 and get thumb ready for action. Press Channel 1 while carefully clutching a bowl of popcorn. Select a category and start enjoying top movies whenever you want on Charter On Demand, many the same day they're released on DVD. Check out this month's newest on-demand choices. Repeat frequently for full entertainment effect. Go to Channel 1 and find your favorite flicks on demand.
Are you searching for health answers? Want to find the best local healthcare specialists? Go to chartertv3.com. Our weekly Health Watch covers all the local health news you need to know. Go to chartertv3.com and click on worcester.md. You can find the best local healthcare professionals, get articles, watch videos, and rate your doctor all with one click. So tune in to Charter TV3 or go online to chartertv3.com/health and access the best local health resources. Charter TV3 and chartertv3.com. Always on.
Coverage from Central Massachusetts for Central Massachusetts.
With graduating students facing one of the toughest job markets in recent memory,
investigators were alerted to the scene late Saturday night for a report of an infant in a car seat in the middle of the road.
Police are calling it a tragic accident. Meantime, tonight we're hearing the 911 call for help made by that father.
Reporters in the field and an in-depth local forecast. Worcester News tonight on Charter TV3.
Charter TV3 salutes Kevin Shea and the Friday Night Football Frenzy Team, winner of the 2012 Media Award, presented by the Massachusetts High School Football Coaches Association. The bump.
Welcome back to the Senior Focus. I'm your host, Attorney Nick Kaltsis. I'm here with Dr. Michael Flynn and with Don Ostguy, and we're talking about prolapse and incontinence. Is this part a normal part of aging?
That's always a wonderful question because normal is such a loaded question. It's kind of like saying, can something bad happen? Of course it can. So normal, no, it's not normal. This is not supposed to happen. Is a common, absolutely, happens to many, many people.
Very common. People
Very
need
common.
to really understand how common it is. A lot of people might be out there thinking, that it is something that only happens to them. That's not the case. It happens to a great many people.
I've got 2 partners. All we do is incontinence and prolapse. Now think about it, for a specialty,
Right.
3 people, and we're just Worcester. I can tell you right now, there's specialists at Beth Israel, there's specialists at Mount Auburn. Very good surgeons, I know them well. But in New England, you probably, in Massachusetts, I would bet there are 15 to 20, at least 20, fellowship trained, people with specialized training, just from the OBGYN point of view. We haven't even talked about female urologists who do this work. So it is very common. If we're all busy and we're all growing, you know it's a common issue.
Now, as far as symptoms, are there particular symptoms that a woman might have? Fevers, being tired, with incontinence, obviously,
If again you look, here's what we say is normal, ideal.
I understand.
Usually when the prolapse is inside the vagina, there's not a lot of symptoms.
Okay.
Sometimes women will say, my tampon keeps falling out.
Okay.
Will be a sign. Some women will describe pelvic pressure, ache, or discomfort. But usually while there's bulges on the inside, there's not a lot of symptoms. There can be. Once it starts to protrude, that's when we start to see symptoms. Certainly this is advanced that I drew before.
Right.
But you can imagine as this was starting to progress, the urethra starts to get kinked. You start to get voiding problems. It's harder to empty the bladder. They'll often feel a bulge while wiping. They'll feel something, and they'll describe a golf ball trying to come out. Sometimes they have to push up to straighten the urethra so they can void. So things like that. But often there's not a lot of symptoms. It'll be pressure, ache, discomfort that you'll see with prolapse.
Are you able to tell by an exam, may I ask? Say someone who hasn't gotten to that stage of everything falling out or starting, can you tell while you're examining a woman that they may have symptoms of it?
I can do an exam, and we have, within my specialty, we have specialized ways of measuring support in different quadrants. One of the things that we've realized, if you ever come to some of our national meetings, is a debate of what is normal. We know that this is not necessarily normal, this is ideal. But we have many, many women walking around whose cervix drops a little bit, whose anterior wall drops a little bit, back posterior wall drops a little bit, who have no symptoms. And you have to ask, wait a second, why can't that be normal? And so there is an undefined point from where it's kind of just a normal variation, a little bit of a bulge, a little something going on, versus actually, no, it's starting to cause problems. Even so, there's nothing I can do to prevent progression. Some people think pessaries might work, but I don't know of any good way to prevent it. I will see many women who will have a little bulge. Their OBGYN will see them and say, you need to go see somebody about that. Maybe you should get it fixed now while you still can. And so in walks a 50-year-old woman who's got just a little bit of a bulge coming down. Maybe it comes to the opening here. Well, it doesn't bother her. She has no symptoms. She didn't even know about it until her doc said something. So again, won't kill you, won't harm you, doesn't bother you. Don't do anything. Wait till it bothers you. Wait till it affects your quality of life. Because I'll often say, here's your quality of life right now. If you want me to do something, you'd want to see me make your life a lot better. Because if I took away this bulge and your life hasn't changed, you accepted all the risk of whatever intervention, whatever medicine, whatever surgery, or whatever I did for no gain. You want to make sure there's a clear benefit. And you should, as you make your decisions about treating something like this, how does it make my life better? You should be able to define that.
So what are the risk factors then, we'll say, for prolapse? Are there risk factors for women?
Pretty clearly obstetrics. Having babies, it's not too hard to figure out you have an opening to the vagina about this big and a baby's head this big. Okay? Babies coming through the birth canal clearly do injury to those structures. However, there's many women who've had 4, 5, 6 babies, who've had big babies, had little babies, who never have a problem. there's also clearly a genetic component. It tends to run in families. So if your mom had it, your sister had it, you know what, that increases the risk you'll have it. Not a guarantee to be sure, but it increases that chance. Then we also see it around the time of menopause and with age. This doesn't show up in 20-year-old women. We sometimes see it in 30-year-olds. It's not really until you start to get in the 40s till I start to see the symptomatic prolapse. And then with menopause, it's not uncommon within 6 months of menopause that we start to see progression. And that has to do with the loss of estrogen support to all this tissue.
How about obesity? May I just ask that, if that plays a part, where some other organs it really does?
Nobody has shown obesity to play a role. In some ways it might be protective because there's so much extra tissue there that it may help hold things up. I've seen thin women with prolapse. I've seen obese women with prolapse. So I don't see a real good correlation.
Okay.
Now again, it's never a bad idea to lose weight, but I don't think it would be fair to say to somebody, lose weight to prevent this. I don't think that's fair.
What about smoking?
Smoking seems to play a role in just about everything.
That's
So
why I
certainly
asked.
smoking compromises connective tissue. And again, as we're talking about prolapse and things falling down, this is connective tissue. This is things that support, hold everything up. While cigarette smoking affects healing. It affects performance of connective tissue. So there is some correlation. Is it strong? No. But if you can quit smoking, again, never a bad idea. And can it help prevent this? Probably for a few women.
And I would assume if a person exercises, it can help them as well.
Exercise, again, is never a bad idea. And I'll have a lot of women say, well, what about pelvic floor exercises and Kegel exercises? Well, the strategy of a Kegel exercise, you can see how I've kind of drawn some bends here. There's a bend in the rectum here, a bend in the vagina. Well, the way things work, right, if you think about the support to a woman's pelvis, right, here's the tailbone, right? What's holding things up between here and here? Right, there's no bone. What there is there's a muscle that sweeps underneath here. This is called the levator ani muscle, or the pelvic floor. So squeezing that muscle can help a lot in terms of incontinence. It can help some with the support here. But again, you want to recognize that squeezing those muscles, strengthening those muscles, is a compensatory interaction. In other words, you're trying to compensate for the defect, which is in fact in the vaginal tissue and the vaginal connective tissue. So in general, I will say pelvic floor exercises are never a bad idea. They can help some mild prolapse. They can help some mild stress incontinence. But make no mistake, that in itself will not always fix the problem.
So physical therapy would be the correct utilization of exercise, is that correct?
Sure, physical therapy, again, particularly for incontinence, can be helpful for mild incontinence and for urgent incontinence. I've got some physical therapists I work with that are just fantastic, really make a big difference.
What about, I'll give you a worst case scenario, real bad case of prolapse and surgeries needed. Can you tell us a little bit, we'll say, about the surgery itself?
Sure. As we talk about surgery, we always focus on the compartment affected. And again, when I do my evaluations, it's very important to make sure each individual compartment's assessed. A lot of the general OBGYNs are some great general OBGYN surgeons out there. Some of them, though, don't always capture the different elements. I can't tell you how many patients I'll see referred saying, oh, she has a rectocele or the back wall protruding. But once you really do the evaluation, you realize actually the top of the vagina is coming down too. Well, that changes things because you have 3 compartments and you want to make sure you address each compartment that's affected. In terms of repairs, there's several ways to go after it. We increasingly are using some minimally invasive surgeries. And that can be vaginal surgery or that can be laparoscopic surgery. A lot of the ways a lot of the patients I will see will have apical prolapse. Apical prolapse means the top is falling down, so the uterus is coming down, or if they've had a hysterectomy, the top of the vagina is coming down. So what I will often encourage, particularly for my younger, really physically active patients, so women who want to maintain the ability to have sexual activity, we obviously have to preserve the vagina. So what we'll do is we say, okay, so again, the top of the vagina is falling down. So a procedure we really like is a colpopexy. Okay, colpopexy, colpos means vagina, pexy means fix the vagina. And so we call it a sacrocolpopexy. So what we'll do, if a woman has a uterus, we usually encourage the removal of the uterus. And the reason for that is because I'm going to do a repair. I'm going to place sutures into a ligament on the tailbone. Not into the bone, into a ligament. I'm going to use a soft piece of flexible mesh, the same permanent mesh that we'll use to fix hernias, and I'll attach it to the back of the vagina here. But then a second sheet I attach to the front of the vagina, which is why I like to get the uterus out of the way. There are procedures I can do that preserve the uterus. They're not as strong, not as durable, and I find that we do it this way, we get a much better repair.
We're going to head to a short break now, but when we come back, I do want to talk about other treatment methods, not only surgery, but also to see, is there some kind of medication that might help people? But we'll head to a break first.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
Please join us on Wednesday, June 20th at the College of the Holy Cross for a special day for anyone interested in learning more about the latest information on heart health, such as heart disease risk factors, stroke prevention, and how you can implement a heart-healthy lifestyle.
When we walk together, we are bigger than cancer. Join the world's biggest fight for more birthdays, the American Cancer Society Relay for Life. Find your community's event at relayforlife.org.
Tired of weather reports that don't focus on Central Mass? Introducing Worcester Weather, the only video weather report for Worcester. Worcester Weather is easily accessible 24/7 by visiting chartertv3.com and is updated throughout the day to give you the best video forecast possible. Worcester Weather also airs at 5 p.m. during the Jordan Levy Show and every Worcester News Tonight telecast. Worcester Weather gives you the local forecast you have always wanted. Worcester Weather on Charter TV3 and chartertv3.com. Brought to you by Berterra Nissan of Auburn.
We are just not going to meet our obligation. I think this council's wrong.
You stand up in that council, you go right toe-to-toe with them. You guys want to talk behind my back? Let's talk right now. Put up or shut up. And I'm going to tell you something, they'd wet their pants. You ever see Mexican jumping beans? They'd be jumping out of their chairs so fast to say, I'm with you, man. I'm with you. I'm with you.
I'm Kristen Doucette from Worcester News Tonight. Thank you for choosing Charter.
Welcome back to the Senior Focus with your host, Attorney Nick Kaltzis. I'm here with Dr. Michael Flynn and Donna Osterguy, and we're talking about prolapse, and eventually we're going to talk about incontinence. I had a very quick question. As far as surgery, are there other things other than surgery, medications? Are there any medications that a person can?
There's no medication. Again, I
Okay.
call this a hernia.
Right.
Just like a hernia, there's no medication. It's either watch it, operate, or do something to support it.
Right. And with the operation, we're talking about.
This is an operation, this is what the FDA actually considered gold standard. As you know, the FDA came out with a warning this summer about the use of vaginal mesh. There's some very innovative techniques that some of the surgeons have been looking at, trying to find ways to place mesh to support prolapse, but doing it from a vaginal approach, trying to be minimally invasive. Really nice techniques, good effective ways. Our problem was they were seeing significant rates of mesh eroding into the vagina or causing other problems. It was something I was seeing. It's not uncommon for me to have to take somebody from the OR to remove some mesh that somebody placed. So that's what some of the excitement is on TV and things like that. The FDA warning that came out last summer that's led to all the controversy specifically said mesh placed this way, so it's coming from an abdominal root placed on the other side of the vagina, not only is safe, but is the gold standard, is the best way to repair apical prolapse.
Now, when you said that it's not uncommon for you to have to go into the operating room and remove mesh that another physician had put in, is that because the mesh falls?
No.
No. Okay.
What's happening is the mesh is inert, so the body won't reject it.
Okay.
Somehow the mesh gets contaminated, so bacteria grow on it, and the mesh gets extruded. Or something happens surgically, there was poor healing. For whatever reason, the mesh merges into the vagina, and so it then needs to be removed.
How long does the surgery take?
For this procedure, well, there's two ways to do it. I used to do a lot of it open abdominal operation. This would be about a 3-hour operation. We now do this minimally invasively. We do this using laparoscopic techniques in the robot. It'll take about 4 hours to do it. Patients are in the hospital overnight. They go home the next day. They're up and walking the day after surgery. They're eating regular food the day after surgery, up and down stairs the day after surgery.
Where's the incision?
The incisions are on the belly. So here's an abdomen, here's the belly button, okay? So if I were doing an open procedure, you'd have a low, sort of what they call the bikini cut down low here, but when I go with the robot, we have an incision here, 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 and here. And occasionally I need an extra incision up here. But through these incisions, not this one's only if it's done open, through these incisions we do the whole operation that I described here, from removing the uterus. If we need to remove the ovaries, we can also remove those. I usually leave those behind. But placing the mesh, doing all the suturing, all of that stuff, we can do it all through those small incisions.
And the laparoscopic incisions are very small incisions, right?
That big?
Yeah, that's small.
Yeah.
So recovery time must be way less for women.
The recovery time in terms of the comfort is much quicker. So you are much more
Less
active,
pain.
less pain, less discomfort. But again, as I keep calling this a hernia, this is a hernia repair. We need to get good, strong healing here. So no matter what route I take, you're going to have lifting restrictions for 6 weeks. No heavy lifting for 6 weeks. You're not allowed to use tampons or put anything in the vagina for 6 weeks and things like that. However, once you're healed, and I see you for your 6-week checkup, I set you loose. I let you do whatever you want to do. No long-term restrictions. The whole reason we're doing this is so that women can exercise again and can be physically active. So the idea that we're going to restrict them from future activity makes no sense. It's not making their life better. And so the need for a long-term restriction after you've had a good, strong repair, you don't need any restrictions.
Now, I know that there are probably a lot of people that would like for us to turn our attention to incontinence. I have a question. Is it possible that a person can suffer from both prolapse and incontinence at the same time?
Very common. The forces that cause incontinence often are the same forces that cause the prolapse. So it's not uncommon that we'll see them coexist.
You know, I've heard the term overactive bladder, and I'm not quite certain that I know what that is.
So again, let's draw another picture of the pelvis. Opening of the vulva again. Here's the urethral opening and the vaginal opening. Okay. There are two types of incontinence that people get. And one of the first ideas I try to hammer home to people, incontinence is a symptom, just like a cough is a symptom, right? If you have a cough, do you just start taking medication, or do you try to figure out what's causing the cough? It might be pneumonia, it might be allergies, it might be something bad like cancer or tuberculosis. So you got to figure out what's causing it. Same with incontinence. So when you're trying to figure out incontinence, you're figuring out, okay, what are the types of incontinence? And we break them down into basically 3 types. There's stress incontinence. Stress incontinence happens when you have a cough or a sneeze, some sort of force coming from above, pushing down in the bladder and pushing urine out, as opposed to urge incontinence. Urge incontinence is when you feel a strong urge, you gotta go and you can't get there. This is the classic gotta go, gotta go. This is when the bladder is contracting uncontrollably. The other kind is insensible incontinence, where it's leaking out and we just don't even know why. You don't even know what's happened, you just realize you've gradually gotten wet. So, stress incontinence, well, to answer your question, overactive bladder. Overactive bladder it's an idiopathic diagnosis, meaning we don't know the cause of it. So it's a diagnosis of exclusion. So when a woman has urge incontinence, is leaking because the bladder is contracting uncontrollably, we try to figure out what's that cause. The number 1 cause is a bladder infection. And many women will say they know they have a bladder infection because they have to pee all the time. They got to go. And that's because there's an infection there, the bladder's irritated, and that muscle's contracting. And that muscle can contract strong enough to overwhelm the continence mechanism. Other less common causes, obstruction of the urethra. Now this is what you see in men. Men get the overactive bladder symptom because the prostate's gotten big and it blocks the urethra. And that causes the bladder to respond by getting a little bit bigger and squeezing much more forcefully to try to push the urine through a blocked urethra. So again, at the end of the day, overactive bladder, which is very common, we don't know the cause. It may very well be neurogenic, meaning that it has to do with nerves not working as well. Other times, we just don't know. This is what we make better with medications. This is where physical therapy really comes into play. Contrast urge incontinence to stress incontinence, because I have a lot of patients coming in thinking their urge incontinence can be fixed with surgery. Now there is some very specialized surgery that we can do for urge incontinence, kind of a bladder pacemaker, but we reserve that for the really severe cases of overactive bladder. Stress incontinence is what we fix with surgery, and that's what we'll commonly see in conjunction with prolapse. Now as I talk about stress incontinence, I want to talk a little bit about what keeps women dry. Right? I've got a daughter who plays soccer, and she runs all around the field, she's kicking the ball, she's running hard, working hard, she never leaks a drop. Well, what's keeping her dry is 2 mechanisms. One is a muscle, and that muscle squeezes the urethra. Does a great job of keeping women dry under low pressure, walking, bending over, up and down stairs, things like that. The problem is if you're a soccer player or ride horses, or if you cough or sneeze, there's a huge force coming down on this bladder. Okay, and this muscle is good, but it ain't that good. Something else is keeping women dry, and it's that vaginal wall. Okay, so the vaginal wall, so if here's the urethra, here's the vaginal wall, you cough, you sneeze, the urethra gets pinched closed against the vagina, no leakage. Okay, women who have stress incontinence, I'll very commonly see, they will look completely normal, nothing's obviously bulging down, but the vagina will go like that when they bear down. Okay, so here's the urethra, there's the bladder, there's the pubic bone. Okay, so as she's coughing and pushing down, what's pinching close the urethra? Nothing. And so this is where women will say, they go running, spurt, spurt, spurt. Every time there's that increased pressure or a cough, they get a little spurt, and it's because we've lost the support to the vagina.
Now, if a patient had surgery for prolapse, had mesh inserted, they did the things that you suggest, can that cause incontinence or not?
Not typically, but if you remember that one of the pictures I drew earlier, if you take a look at this picture here, right, I'm showing a little kink to the urethra. So women with prolapse this bad, they often don't have any incontinence because it's kinked, just like a hose, right, a garden hose. If I do surgery and I put in that mesh, I pull everything up, I just straightened out the hose, and I might expose a weakened sphincter. And the reality is, as much as I'd love to say I can repair everything perfectly, I can't. I can't make it the way God made it. I can repair, I can refurbish, but I can't make it perfect. And so when I do my repairs, I don't always have the best support to the urethra, which is why for stress incontinence, we have a separate surgical procedure just for stress incontinence to make that better. And we're very effective there.
So is it age-related, would you say? I'm hearing you say that stress incontinence, weakening of muscles. And for whatever reason, childbirth, there's a million and one reasons probably why it could happen. But I would think with age, as time goes on, muscles do get weak as you age. Would you say that that's a factor, is an age factor in it, or no?
Age is clearly a factor.
Okay.
Because again, you'll have many women having babies. I mean, take a look in the 1960s. Everybody had babies in their late teenage years, in their 20s. Incontinence doesn't show up until mid-30s, late 30s, and really in the 40s. That's when we start to see the stress incontinence. So there's more to it than just a childbirth injury. But again, this is not so much a muscle problem. Many women will come to me almost in tears because they say, I've been doing Kegels forever. My doctor says I must not be doing them right. Why aren't they working? That's because Kegel contractions compensate. They're not part of the original mechanism, right? The mechanism is that vaginal support, not the muscles supporting the vagina and rectum. Okay, it's the support here. And that's what's been lost.
Going to head out to a short break right now, and when we come back, we'll talk about more prolapse and incontinence.
Millbury Healthcare Center is a highly respected 5-star deficiency-free skilled nursing and rehabilitation center. We are renowned for our compassionate care and specialty programming, making it possible for your next step, returning home. We listen and take the time to understand your goals. We provide support and the tools needed to safely prepare for your transition home. Millbury Healthcare Center is the community choice for skilled nursing and rehabilitation.
Does your loved one suffer from memory impairment, dementia, or Alzheimer's disease? Consider Dodge Park Rest Home in Worcester. Our geriatric medical team and nursing staff are available 24 hours a day. We offer medication administration and incontinence care with dignity. Our activity programs are designed to engage and stimulate the mind. And with Dodge Park Rest Home, you can better protect your estate and save your assets with only a 1-year look back. Your loved one will feel safe and at home with Dodge Park Rest Home of Worcester.
Please join us on Wednesday, June 20th at the College of the Holy Cross for a special day for anyone interested in learning more about the latest information on heart health, such as heart disease risk factors, stroke prevention, and how you can implement a heart-healthy lifestyle. Help the American Cancer Society save lives and create more birthdays by joining the Relay for Life of Worcester, sponsored locally by Charter Communications and Charter TV3. Relay is a unique community overnight event that allows teams of families, friends, and co-workers to join together in the fight against cancer. Form a Relay team this year and make a difference. There are 14 relays taking place throughout Central Mass this year. For more information on a Relay event in your area, visit cancer.org and register your team today.
I'm Tom O'Donnell, Chief of Police for the town of West Brookfield with an important safety message. This time of year, thousands of high school students are going to proms. Parents and teenagers both have a responsibility. Parents, talk to your teenagers about the expectations and limitations. Teenagers, the prom is a rite of passage. Listen to your parents and have a prom night that is fun, memorable, and safe. This safe driving message is brought to you by the Central Massachusetts Chiefs of Police Association and Charter Communications.
Join me on the Hank Stoltz Experience. You know, people are always asking me, what is the experience? Well, that's the beauty of it. It's everything that has to do with Central Massachusetts, from the politics of the region to the great events that are going on each and every weekend or every night right here in Central Mass. It's everything that's going on. It's everything that you want to know about. And just like Kelly Square, where the traffic never stops, we never stop either. There's no red lights on the Hank Stoltz Experience, only on Charter TV3.
I'm Andy Lacombe from Worcester News Tonight. Thank you for choosing Charter.
Welcome back to the Senior Focus. I'm your host, Attorney Nick Kaltzis. I'm here with Dr. Michael Flynn and Donna Osterguy.
I know, Dr. Flynn, that we were talking about various incontinence, the types that there are, and some of the issues that people face. And I know that during the break I was just mentioning the fact that for a while I stopped jogging, learning how to jog, even because of the fact that I was afraid of incontinence happening. Even in your 40s, 30s, even 20s, you might see patients who have that same type of incontinence issue where it might be exercise related, and how truly it doesn't matter whether you're 70, 80, 60, it's not an age related factor in some cases.
The key for taking care of that kind of a problem, again, it's usually going to be made better with surgery. Physical therapy can definitely help, particularly if it's mild, and I've seen a lot of people get better with that, so it's always worth considering. But for the people who are going to move on to surgery, I think one key consideration is being sure you're done with childbearing. Because again, the forces that caused the injury to begin with is having a baby come through here. But if you've agreed, if you decide, all right, I'm done with babies, I really want to get this fixed, and it is stress incontinence, and that's something we need to diagnose in the office and really make sure there's nothing else going on. The technique we like to use is a mid-urethral sling, which is a simple outpatient ambulatory surgery. So we come in the morning, home in the afternoon. We do it under a light general anesthetic. It involves an incision in the vagina here, 2 incisions above the pubic bone, and I just pass 2 needles, go down and out through the vagina. They're just there to help grasp a piece of mesh. And I'll take a piece of mesh about this big, long, narrow piece, and I pull the needles back out. And what that does is it pulls a band around the urethra like that now, okay? So again, here's your urethra. Now I've put a band around it. What happens now when you cough, sneeze, exercise, any increased abdominal pressure? That urethra gets pinched closed against the band. Works beautifully.
And are these procedures that we've been talking about something that's typically covered by insurance?
I've never seen a problem with insurance covering any of these procedures. They're clearly indicated. They've got a wealth of support behind them, so it's never been an issue.
So someone's having an issue, they're suffering from having symptoms, they can feel comfortable, they can go to their physician, and if there's particular treatment that's rendered, the cost of that treatment is typically covered by insurance.
I've never seen a problem.
Okay.
I want to mention too, Dr. Flynn, your phone number, because there may be many of our viewers out there wondering, how would I find out about a specialty like this, where you're saying this is your specialty? Many physicians and primary care physicians, especially for seniors, don't frequently, or they don't even feel comfortable talking to their primary care physician. You are, in a sense, the guy to speak to about this type of issue. I'm going to give out the phone numbers for Dr. Flynn. It is 508-334-9840, and that is your clinic number.
That's my clinic number. In addition, I've got 2 partners, Dr. Joy Saney and Dr. Danielle Patterson, both of whom are excellent. I would take care of my wife, my sister, and my daughter without hesitation. So all 3 of us all have very similar training and experience and have the same focus.
So we're going to talk a little bit more about incontinence. I see on the TV a lot. I actually had a study I had gone to, and they had talked about drugs to treat incontinence. What's your views on that?
Drugs, by and large, do not work for stress incontinence. And again, I think I've shown here it's an anatomic problem. The oral medications can be very helpful for overactive bladder. What I've seen is by themselves, they don't work very well. I strongly encourage my patients to pursue other treatments, giving up things like caffeine and alcohol, which are big-time bladder irritants. I tell my patients, if you're going to have a couple of cups of coffee, expect gotta go, because that's what caffeine does. If you don't want gotta go, don't have caffeine. A lot of people are not happy with that.
That's an interesting factor, though. I mean, for
it's
seniors, my mother who has her 2 cups of coffee and has the occasional, have to go, maybe that's a good reason to cut it out.
I'll give you a great story. When I was a resident, right, I'm OBGYN resident, okay, I'd get to the hospital at 5 a.m., I'd be rounding, I'd be on labor and delivery, I'd have a full day. I would use the bathroom when I first get up. I'd probably go to the bathroom around 12 noon, maybe 4 o'clock, and then when I get home at 7. I didn't drink coffee. Once I became an attending, so I'd finished my residency, I started practicing, friends got me into coffee, and very quickly I went from not using the bathroom before 12 noon, I'd have to go 3 times before 12 noon. I quit coffee about 4 years ago. I went back to not going very frequently. So it's a well-known bladder irritant that will cause urgency and frequency.
So can I say that there is some lifestyle or like changes that might help not having water after a certain time, so something to that effect?
Not having water late at night will help with nocturia and getting up a lot at night to void.
Okay.
I will say there's a lot of fallacies out there about how much water to drink. You've heard you're supposed to drink 8 glasses of water a day to be healthy. There is no literature to support that. Some people will say drink water till your urine's clear. That way you know you're well hydrated. Well, the reason your urine's clear or looks like water is because you're overhydrated. You have more water than you need. That's why your kidneys are getting rid of it. And something that people have to remember is whatever you drink is what you will void. So if you drink 3 liters a day, you will have to void 3 liters a day. So you should expect to void frequently if you're going to consume 3 liters or more.
That's an interesting fact, because you've heard it so many times,
It
especially
is.
we'll say gym health fanatics who always say, oh, you have to have at least 8 glasses of water a day, this much water. So truly, it's not necessarily a factor of your body needing it, especially if the output is so clear. That would tell you that it's just coming right back out.
Again, that's general recommendations. There clearly are people with medical conditions that do need to consume extra fluid, so obviously they need to listen to their physicians.
Would emotional health cause incontinence?
Really hard to see how somebody's emotional state is going to cause a problem.
Okay.
Having said that, I've got patients with dementia who don't know enough to get up and use the bathroom. I have some people who emotionally are disturbed enough that their behaviors affect frequency of bladder emptying and affect the function. But again, that's obviously a behavioral effect on the organ as opposed to it's causing a disease.
Right. And I presume that if a person is suffering from incontinence, they can become emotionally distraught over that, but rather than having an emotional issue causing incontinence, they can be depressed because they have incontinence.
Certainly this is something that we've done a lot of investigation of, and there's a clear correlation between depression and incontinence. I don't think anybody has shown that one definitively causes the other, although it's pretty clear if you've got incontinence and you're wet, it's not too hard to see how that really is going to lead to depressive episodes.
And just briefly, we have about 30 seconds left. As far as complementary or alternative treatments are concerned, acupuncture, for instance, I am very much sold on acupuncture. Could acupuncture or some other alternative therapy help these kind of things?
Certainly could play a role for overactive bladder, which is more of a functional issue. It's hard to see how acupuncture is going to help stress incontinence or prolapse, which are really more anatomic issues. I'm not going to say it doesn't work in those situations, but I don't see how it would.
We're at the end of our show. Dr. Flynn, thank you for taking time out of your schedule to come in today. Donna, thank you for coming in today, and stay tuned. Jordan Levy is next.